Okay, this is the last that I'm going to do. We will start class Tuesday morning with diabetes insipidus. We're going to look at drug therapy for growth hormone excess. There are somatostatin analogs that are used. They inhibit growth factor. They also inhibit the IGF-1 via a negative feedback, and they'll work in 50 to 70% of patients. Now, drug therapy can be used either by itself or in combination with surgery or radiation. The most common drug used is going to be octreotide. It is given sub-Q 3 times a week or as a depot injection every 2 to 4 weeks. Now, you may have seen octreotide show up in your GI readings. Octreotide inhibits GI and pancreatic function. So long-term use will cause digestive problems like loose stools and nausea and gas in about a third of patients. Okay. In addition, about 20% of patients will develop gallstones. The good news is they're usually asymptomatic gallstones. So that's octreotide. Now, the growth hormone receptor antagonist, think about what that means. An example is pegvisomant. It modifies growth hormone action by blocking growth hormone-stimulated liver production of the IGF-1. IGF-1 is the main mediator of the somatotropic actions of growth hormone. So you need those insulin growth factors to mediate growth hormone. This is also an injection. It's either daily or weekly. And it's going to be used for patients with surgery or radiation therapy, but still having hypersecretion. So it's used in combination. It'll normalize the insulin growth factor 1 in 90% of patients. But again, this is not appropriate for primary treatment because it doesn't act on the tumor itself. Now, the dopamine agonist. An agonist is something that produces a like effect. It's the opposite of antagonist. So dopamine agonist, bromocriptine, mesylate, cabergoline, those are a couple of examples. They stimulate dopamine receptors in the brain, and stimulating these dopamine receptors can inhibit the release of many pituitary hormones, especially growth hormone and prolactin. In most cases, small tumors will decrease until the pituitary gland is of normal size. Now, side effects to the Parlodel include orthostatic hypotension, GI issues like nausea, vomiting, cramps, constipation, also headache. The treatment on bromocriptine starts with a low dose, and then you gradually increase up to 20 milligrams a day. It is important to stop Parlodel if pregnancy occurs. And then the last medication is cabergoline. In one study, it was shown to be more effective than bromocriptine, up to 30% more so than the bromocriptine. I think that's all that I wanted to tell you about the management of growth hormone. Now, we've talked about general pituitary issues. We've talked about hypopituitarism kind of globally, and then we talked specifically about growth hormone deficiency and growth hormone excess. And then the last thing we talked about was the care of the patient with growth hormone excess and the surgical care of somebody with a hypophysectomy surgery. So we will start Tuesday morning on diabetes insipidus. Catch you later.